Is this on? This is supposed to be on.
It's on.
Can you hear me? Is that okay? Okay. Is this okay? Okay, great. Okay, so our main areas of research that we're going to talk about today here, okay, are assessment tools, which are needed for clinical care, but also very importantly for treatment trials. Biomarkers, which are very desired and would greatly improve our ability to treat and manage patients, as well as facilitate conducting treatment trials, but this is a work in progress. Then genetic studies, environmental studies, which are to identify potential risk factors, disease processes, and so potentially to identify new targets for treatment, and then clinical trials. So clinical measures then, these again are to help us assess. So mainly we want to assess disease activity because that's what we have treatments for at this time, but we also want to assess disease severity because it may help us with stratifying patients for treatment, as well as this is a consequence of having persistent activity, and so we want to be able to monitor progression and improvement. So skin features, as you're all aware, is a very important thing to score for our patients. So skin thickening, it's a shared feature between both the pediatric localized and the systemic sclerosis. And it's a tough measure in the sense that it represents both activity and damage. So early on, we have induration, which is swelling from that inflammation, and there's a little bit of fibrosis. But later on, we only have the fibrosis. So if you remember the slides I showed you where the one on the far right was just all homogeneous, that's just didn't have those inflammatory cells, that's just damage. And it can be difficult, if probably impossible, to distinguish some of those stages. So we're scoring this by gently wrinkling the skin on that 0 to 3 scale that Dr. Stevens mentioned. And for systemic sclerosis, we're summing it across the body sites with that modified Rodnan skin score. And for the localized scleroderma, we're also summing it slightly different sites. This is based on the low-C, low-SCAT measure. And this is just an example. So 0, we can easily wrinkle the skin. 1, it's a little bit harder. 2, it's a little bit more harder. And then 3, it's sort of like rock hard. So other skin features that we want to check, erythema, so red color that you can see here around this whitish area. Okay, and this is more prominent in localized and systemic, but early in systemic, we do have erythema too. It's a major activity feature we found for localized, so it's really weighted very highly by physicians. And so you could see with this patient with treatment, that redness went away. So additional activity features for scoring are if it's a new lesion or enlargement, if it's got violaceous color, if it's white, waxy, or yellow, so that's these areas here, which will have some thickening too. This kind of thickening is easier to tell that that's an early active sign, and if the lesion is warm. And then we have a composite skin measure for localized scleroderma, which is based on the low-C and has additional variables that we identified in prospective study from Locus, which improve the sensitivity, and that's summed across sites, and we found that this is valid and reliable, meaning that physicians can consistently score it with training. Then we want to score extracutaneous involvement because we are all very concerned about this. So our localized scleroderma group in CARA developed a morbidity measure. And this includes the major extracutaneous problems. And we generated weighted scoring because some things like a hip joint is probably going to matter more than your pinky joint. So we used something called Thousand Minds process to develop that, as well as consensus methodology based on looking at numerous cases. So as I said before, musculoskeletal involvement is common, and we weighted the joints differently for which joint, as well as the limitation level. We're also scoring muscle. Growth issues is a major concern, so we have ratings also for that, for if it's of the face, head versus trunk or limb. We are scoring head and neurological issues, which is a bit harder for us to know how much to weigh those. So that's a work in progress. And then other organs are captured, but that's rarer. And so we found that this measure is correlating better with physician assessment of damage than just looking at skin damage features. So scoring extracutaneous involvement in systemic sclerosis is also important. So in the SCORE study, which is a Scleroderma Foundation-sponsored study that Dr. Torok is the PI and Dr. Stevens and I are the co-I, we are going to be evaluating different ways to assess some of the organs. And we're also trying to develop a composite disease outcome measure, which is based on the adult work on what's called Combined Response Index in Diffuse Systemic Sclerosis, or CRIS. This outcome measure looks at several features, so not just the skin scoring, also lung, also patient and physician assessments. And it's likely, it already is becoming a major tool for clinical trials, probably shows better responsiveness than just looking at these parameters individually. Dr. Yvonne Fulveri in Germany had set up a meeting last year to develop the pediatric CRIS that we all participated in, and we're very fortunate that the adult systemic sclerosis expert, including Dan First, Dinesh Khanna, Rick Silver, Philip Clemens, are very supportive of this effort, so they're participating so we can learn from their experience. And we have pediatric rheumatologists from the US, UK, and Europe, as well as other specialties like cardiology, pulmonology, GI participating, so we hope that this will be a very accurate as well as sensitive measure. And we are all leaving for a meeting in Germany in another month. Looking forward to that. So imaging and other assessments are also helpful for extracutaneous involvement, especially deeper tissues. So for localized, we do ultrasound, magnetic resonance imaging, MRI. Also has been done thermography, which is looking at the heat, and laser Doppler imaging is looking at the blood flow, which is probably what ends up showing up as heat. Those are more research type of tools, not so commonly done. Phase 3D imaging, cone beam CT, those are helpful for evaluating the patient for potential surgical correction, possibly for monitoring, though cone beam CT has a disadvantage that that's radiation. For systemic sclerosis, we have pulmonary function test CT of the chest, as you've heard about, echocardiograms, cardiac MRI is being explored, though this is a very difficult test for a child where they have to hold their breath about 40 some times in 45 minutes, esophagram and other GI evaluations, and as Dr. Stevens had showed you, CT of the chest can help us track changes. So this is before treatment, one of Dr. Torok's patient, and after treatment has improvement. So ultrasound then we have found is helpful for monitoring activity. So this was developed by a collaborative localized scleroderma group. This is localized scleroderma clinical and ultrasound study group, which was based in Karis. So we developed standards for scanning and scoring the scans with radiologists. And this allows us to evaluate deeper tissue, and we found this has good correlation with disease activity. So this is one of my patients who had longstanding linear scleroderma. This is of her finger, which was one of the earliest sites before I saw her. So you could see that there's atrophy here with some dyspigmentation. This finger is a little bit shorter. And she was complaining about pain, but clinically I didn't find any obvious activity signs like redness or warmth or skin thickening. And so we did an ultrasound of this site as well as other sites. And so the way we do ultrasound is that we're looking at the tissue thickness, the brightness, and the blood flow. And all of those qualities vary depending on what your age is, what your sex is, which body part you're looking at. So you want to compare it ideally to the unaffected side, which is an advantage we have usually for localized scleroderma, that it typically is unilateral. So we looked at her unaffected side compared to affected side. So you could see that there's thinning of the tissues on the affected side compared to the unaffected side, which we could tell just by looking at her. And there's sort of a loss of the differentiation of the tissue layers because everything just got smushed together because of the loss. But I think what's obvious is that there's a lot of bright color here, which is the Doppler color, and so that's blood flow. So there's a lot more blood flow on the affected side than the unaffected side. And then when we treated her, which I wasn't treating her specifically for that, she had more obvious activity elsewhere, her pain went away and then this cleared up. So it can be helpful because again, clinically, we couldn't tell that there was anything here, but the ultrasound. So we can track changes over time. So MRI is also used for joints and deeper tissue involvement. So this is a report from a study by Usler last year. So he found deep tissue involvement in 65% of his patients, which could be fascial thickening and edema, which shows up as brightness here. And then superficially, you might see that there is thinning. So this layer of fat, the dark tissue out here, you don't see too much of that. And there can be infiltration and atrophy of that fat layer. And another researcher, Chance, also found that you could track changes in response to treatment and deep morphia. We have found that MRI is not as good for superficial tissue as the ultrasound because of technical issues, that the ultrasound is much better for superficial, but the MRI is much superior for deeper layers like the joint or the bone. And then this is 3D facial imaging, where you can monitor the progression of the subcutaneous atrophy of the face. This is from Dr. Torok. So she works with her plastic surgeon. So this is an example of facial reconstructive surgery. So this is the imaging before. So we could see that there is some asymmetry in the face here on the right side, and there's some thinning here. And so this is the patient before. And then with the surgery, there's less of a depression, less wrinkling in that affected area. Okay, and then there's a technique being developed called Computer-Aided Lung Informatics for Pathology Evaluation and Rating, or CALIPER. This is being done by Dr. Mikhail Sidon at Children's Hospital of LA, in collaboration with Drs. Torok and Stevens. So this is a quantitative CT assessment of children that have lung disease and systemic sclerosis. And so, part of the issue with evaluating these patients is, CT is a lot of radiation. It's very difficult, the radiologists will tell you maybe it's like 20%, 25%, but we're hard to get to small percentages. So this is a way to potentially better quantify it so that we could better monitor this. And and the technique is based on looking at the abnormal signals, but also the abnormal signals represent different processes. So to quantitate the different ones, and so it's taking that CT and it's color coding for whether it's ground glass, reticular, or other kind of problem, and then we can get this glyph that sort of summarizes it, and so we could potentially then more sensitively monitor the disease state. Another tool that we're trying to develop is patient-reported outcome, or PROs. So this is where it's really important for the patient and the parent to tell us what is important. What's been found for other diseases is that what the physician thinks and all these tools that we're using and the lab tests, it doesn't fully capture the disease effect or impact, so that the patient and the families have a great deal to add to tell us what's important to them, what matters, so that even though we might think you're doing great, you're telling us methotrexate's horrible and my child's life has been really impacted by that. So the idea is that we are trying to more fully capture the disease impact, and therefore being able to address all issues that will affect the child's quality of life. And this is also greater emphasis in current drug trials from the FDA. So we're trying to, again, develop these. And so we've done some exploratory work through Kathryn, Pediatric Scleroderma Registries, to add some of this. So for systemic sclerosis, it's become clear that gastrointestinal symptoms and issues really impact the global well-being. And so that we're going to be piloting a GI survey called GIT2, which was developed by Dan First at UCLA, for adults in our pediatric patients. And for localized scleroderma, we've been using some measures that are used for other rheumatic diseases, and we find that school impact, treatment, and emotional functioning seem to be the greatest issues for our patients. We've also asked parents to rate, and we find that the family impact could be worse than the child impact. So this disease does not just affect the child. And then Dr. Ardalan with Dr. Torok has led focus groups to get further insight, and different groups had developed specific PROs for the head or general involvement or adult skin. And this is just showing that some of these things are significantly different in our patients compared to others. So then turn it over to you.
Switcheroo. address. So we'll see how this works. Okay. Alrighty, so thank you, Suzanne. That was kind of the introduction to clinical outcome measures, et cetera, that we're using. But in tandem, we also want to use blood biomarkers and things of that nature. One, to kind of see if any of these can be, predictors of disease, progression, maybe classify the disease a little bit different, maybe help see who's going to be a responder or non-responder to medications, et cetera, and as well as pathogenesis. What the heck is causing scleroderma? Will some of these markers in the blood or the skin help us tell the story of why this is happening, and then potentially even be a therapeutic target that might be used with therapies that are available now, or therapies that we may basically evolve over time from this research. I just need to make sure I'm hitting this right. Okay, all righty. So, we're studying these immune patterns in the blood and the skin. So basically things that I mentioned to look at disease characteristics, responsive therapy, et cetera. What we can look at proteins that are in the blood and the skin. We can look at cells in the blood and the skin. We can also look at gene expression like DNA or RNA. This is a lot to cover, so I'm just going to pick one thing and show you how we can use kind of big technology and then use that to narrow down to maybe just a few biomarkers of interest. So that's why I mentioned using this new technology maybe to see the forest through the trees, or actually the opposite as well, the trees through the forest. Like you're looking at all this data, all these markers, what ones are important. It will help us narrow that down so you can see which one of these markers or immune markers are actually kind of contributing to the disease. This is just a list of the different technology that's out there. I'm just going to talk about Luminix, and that's basically a technology where you just put a little tiny bit of serum from the patient, put a bunch of different patients on one well, and you run it. And instead of just looking at one protein, like, for example, TNF-alpha, something like that, you can look at 60 proteins all at one time because they can kind of get it all on one bead. So using kind of more new age technology to kind of look at an array of immune markers, because we don't know what markers are important in scleroderma right now. So it kind of looks at the big array so you can get an idea and narrow down the ones that are significant or the ones that are higher in scleroderma compared to healthy, or higher in scleroderma when it's active versus inactive. So this is the one protein or the one tree story. Then start off, so then to build up the forest. So specifically, I'm going to talk about this one protein or biomarker called CXCL9 in localized scleroderma. And I also wrote morphia because the morphia is also the same terminology. It's just dermatologists tend to use one terminology and then rheumatologists tend to use the other. So I'm going to tell the story starting about where I started off. I started to look at something that was easy to get. I could get blood pretty easily from my patients. They're getting a blood draw, get a little bit of extra specimen because they're getting blood anyway for methotrexate monitoring, et cetera. And then that extra specimen, that extra blood draw, spin down, get the sera, and then we can kind of look at a bunch of patients over time and see what their protein profile looks like. So I took about 70 localized scleroderma patients and compared them to a bunch of healthy controls that were age and sex matched, because you have to compare kids to kids. That's kind of a lesson in research. The immune system's a little different in kids versus adults. And then so when we looked at that, particular ones that we really wanted to focus on were the ones that had active phase of the disease. So we actually took blood samples from patients that we were seeing in clinic, and when they had active disease, not on treatment yet, typically treat with methotrexate, steroids, and/or Celsep. And then, years later, we would collect a blood specimen when they're kind of in the inactive phase, nothing seemed to be active, and actually compared the patient to themselves in this study. A few proteins popped up using this big 60 protein panel, and the two that I was going to kind of were interest of were interferon gamma related. So see if I can use this. So the interferon gamma related. So that's this particular cytokine that can kind of like go down one immune pathway. So there's certain what we call chemokines or proteins that are associated with that interferon gamma. So the ones that were associated with that were CXCL9, CXCL10, or CXCL11. So I'm just going to focus on CXCL9 because that, when we looked at the clinical features, like when you guys see me doing the skin scoring, that low SCAT or low C-score that Dr. Lee was mentioning, or the physician global, that seemed to correlate the most with the active disease. So we kind of focused on that guy. We went ahead and looked and stained in the skin, and this was the blood, remember, but then we also said, hey, is it important in the skin as well? And it does seem to be important in the skin. It does stain in the skin, and I've found this as well as independently. Heidi Jacoby, a dermatologist in UT Southwestern, also found the CXCL9 and the related markers to be in the skin as well. So that seems kind of interesting. We found a protein in the blood, and then saw it was in the skin as well in the localized scleroderma patients. Maybe this interferon gamma signature has something to do with active disease. It looks pretty promising. Now, Dr. Jacoby and at UT Southwestern, Dr. Richmond actually, before I kind of got involved with the research, and now we're kind of all working together, and Dr. Richmond's at UMass, but they actually were starting to work on this morphia mouse model. So since this was kind of in the works, we said, okay, so morphia mouse model, what does that mean? It just means a mouse that starts getting inflammation in their skin, and then it starts getting the fibrosis or the collagen laying down in the skin. So the skin, when you biopsy it early and then later, does look like a localized scleroderma lesion. So we said, okay, well, there's a new mouse model that they've developed. Let's see if this protein that we're talking about, CXCL9, see if that's important. Do you need it to get the skin thickening? What if you block it? Does it stop the skin from getting thickening? From getting thick, and we've got some interesting results. So this mouse is called we call it the morphia mouse model, but basically you're using bleomycin, which the adult scleroderma patient researchers use a lot to induce like a systemic scleroderma sometime kind of mouse, but basically you're causing fibrosis, so you're injecting this into the mouse, and then the mouse that you kind of inject as a sham, like placebo we call that, just saline, just injecting saline, you would expect the hair to grow back. So they shave the mouse, they inject saline in one and injected bleomycin in the other. So the saline one, you'd say, okay, the hair should grow back, and it did. It's hard, sorry this didn't project, but the hair grew back. But the hair did not grow back in the one with bleomycin, just showing that this is a good mouse model. The bleomycin caused the fibrosis, okay? So this is the morphia mouse model. The bleomycin in this mouse makes it look, like morphia or localized scleroderma. So this is just the biopsy. This is before we're even talking about CXCL9. This is just talking about the mouse. So there's the mouse that just got the saline or the placebo, their skin under the microscope, and it looks pretty normal. And then day 5, after you're injecting this bleomycin to make it turn into morphia or localized scleroderma, it starts looking like that. It gets some inflammation where we'd expect, and the collagen just starts to lay down. Then day 12, it's looking more fibrotic or sclerotic with more of that collagen starting to lay down. Okay, so we say we have a mouse, if you biopsy the skin, it looks like morphia or localized scleroderma. So we're like, okay, this is a decent model to use. So now let's see what CXCL9, now we're gonna play with CXCL9, that protein I talked about. So what we did is just look in this bleomycin mouse that was getting, the mouse that skin was getting injected with that bleomycin, and we're saying, okay, well, we saw the dermis, the skin changes like morphia or localized scleroderma. Well, what is the protein expression? And we found that the protein in the skin of the mouse looks similar to the protein in the expression in the human. So it was upregulated. So you can see that higher levels in the mouse that had the bleomycin injection or the morphia mouse model. Then what if we block the mouse's ability to make CXCL9? We actually block the thickness. So this is a normal mouse that just got the saline or the sham injection. And then this is the mouse, this is the bleomycin mouse, so it got thicker skin, which is as expected. But if we took its ability, it's called a knockout, if we took out the mouse's ability to make CXCL9, we showed that the skin didn't get thick like we would expect after you're injecting that bleomycin in there. So it didn't have the CXCL9 to kind of make that fibrotic response. So CXCL9 probably has something to do with making that thick skin. So that's kind of promising, but that's just kind of one story and one target in localized scleroderma. I think we obviously were writing grants and trying to investigate this mouse model and this protein more, and how does it interact with the cells, things like that. So it might be exciting. There's actually medicines right now that can kind of inhibit CXCL9 pathway, but indirectly. But there might be a medicine down the road that actually directly blocks that. That might be interesting. So these are things just to think about, just to show you that we're getting somewhere. We're getting human data, we're getting mouse data, we're moving forward, we're identifying some markers. But this is just one marker. This is one tree. As I mentioned, the immune system interacts with each other. We got to see what the other trees are doing to make the forest. So we need a team effort to do that. So we're utilizing the CARA registry, as Dr. Lee briefly mentioned, and through the Scleroderma Foundation got a generous grant called the Scleroderma Collaborative Research Grant, which is multi-center site, which is going to identify some of these immune phenotypes. So look at the cells, look at the proteins. So this was just kind of my cohort in my lab, but we're expanding out to 18 centers across the nation that are dedicated into collecting these blood, if they have skin biopsies available, et cetera, as well as the clinical data to kind of pair up with that blood data. So these are the main investigators. I thought the Ghostbusters reference was relevant given it's Halloween time. So you know us because we're up there, okay? But then also Kelly Mazowski's We Need Someone at CARA being our advocate and helping to coordinate this as well. And these are the CARA sites that are involved in this study, and they're listed here. Some of you guys in the room may be interested, but maybe not at a CARA site, but I'm sure any one of us at a CARA site would be happy to see you, and you keep following up with your regular peds rheumatologist, but if you're really interested in getting in the study, I'm sure we could see you, kind of get you in the registry and just kind of see you here and there. So those are the centers, and we're really excited. Pittsburgh would be the biorepository site. The initial goal is to really focus on active localized scleroderma patients and also systemic, but with the localized scleroderma patients, it's the patients with the new lesions, enlarging lesions, the clinicians about to start therapy. Part of that reason is we also want to expand some of the work we've already done on the consensus treatment plans to kind of see that whole methotrexate versus CellCept. We still don't know which one is superior. We know both are relatively affected. But just to kind of kill two birds with one stone, see what the medicines are doing and how they're working, but also collect this blood in the more active patients. And then the systemic scleroderma patients, they're just basically all comers just because this is more rare in pediatrics, so we're happy to enroll anyone with the systemic sclerosis in the registry. And then these are the general things we're collecting. We're collecting the peripheral blood, as I mentioned. We're going to be looking at some of the cellular markers, some circulating cytokines, some antibody profiles, and then standard lab evaluation. So if you're getting a SED rate or a CBC at your local institution, that will be kind of funneled through there as well to see if any of those markers kind of play into this, as well as some clinical markers, including quality of life assessment too. So we're trying to see if these things feed into one. So if they make like a certain subtype. So one of the things we're looking at is there a biomarker that we could use for active disease? It's kind of easy if a patient walks into us, they have a red hot new lesion and it's expanding for us to say, okay, that's active, let's start you on some medicine. But it's harder if you've been treated for a couple years, we're weaning you off medicine, everything looks stable, and then the lesion starts to get a little pink or maybe a little itchy or feeling funny, to know if it's active yet. And instead of like missing that window to treat, it'd be nice if there's some kind of blood biomarker that we could tag on to that. So part of this study in SCORE CARA is to kind of collect this and see if there's some universal kind of biomarker that's just a couple things from the blood, a couple clinical markers that could come together and help kind of predict that. And these are the contact information. As I mentioned, this is kind of a group effort with the main leaders being myself, Dr. Lee and Dr. Stevens, and then my coordinator as well, and Ann Denos is the contact at the CARA registry. So now we're going to switch gears a little bit. So we talked about bench science world, but I don't want you to fall asleep. So we're going to talk to you a little about clinical medicine, some of them, most of them that are existing right now, and where we are with clinical trials, et cetera. Yep. Thanks. Sorry. That's why you're looking at me funny. I have this attached.
Anyways, we're twins. Okay. So I think it's a very exciting time in scleroderma research in the adult world and that way in peds too. So
Okay, so I just wanted to give sort of an overview of clinical treatment studies. So this is just past, present, future. So there are different types of studies that are done. So there's retrospective studies, which means that all the data has already been collected, and this is basically a chart review to try to see, oh, you know, we identified these patients that were treated with methotrexate, how did they do? And sometimes it's a case controlled. But the best kind of studies are prospective studies, which are two types. They could be observational and they could be interventional. So we start off and we decide we want to study this, and we decide these are the parameters we want to study, this is the patient we want to study, and we go forward. So this SCORE study that Dr. Torok talked about, that's a prospective cohort study, okay? Then what's typically used for evaluating treatment is what's called a randomized control trial, RCT, double blind, meaning that you don't know the patient on arm 1 is on drug, or they're on drug 2, or they're on placebo, and placebo-controlled trial. So typically this is 2 arms. One arm is getting treatment, one arm is getting placebo. And the doctors don't know, the patient doesn't know. Only the coordinating center knows. Often the patients are randomized by some kind of random number generator, and so it decides, okay, you know, patient 1, 2, 3 are in arm 1, and patient 4, 7, et cetera, are in arm 2. So this is considered the gold standard for treatment trials. And what I had mentioned before was that there is one of these studies that was done in localized scleroderma for methotrexate. None have been done in systemic sclerosis. Really, no treatment trials have been done in systemic sclerosis for kids, just because it's rare and it's harder. So there are issues with doing treatment studies in pediatric scleroderma, like, as I'm sure some of you are thinking. So there's a rare disease, you know. So the incidence for systemic sclerosis in the UK was said to be basically, you know, less than 1 in a million, okay? For systemic sclerosis, we're higher, maybe we're up to 27 per million, but that's not a super high number. There are varied features, as I hope you sort of appreciated what we talked about. There's different subtypes for both localized and systemic, so are they all going to respond the same to treatment? I already told you that there's a mild and there's moderate severe, so the mild we don't even consider for these kind of treatments we're talking about. Then within each of those subtypes, patients have extracutaneous involvement, and this is also going to vary. So how does that influence things? It can be difficult to detect some of these early extracutaneous involvement, and it can be difficult to detect small changes in progression. So lung disease, for instance, which the caliper looks great, but that's still work in progress, so that's really not ready for prime time at this moment. Growth defects in juvenile localized scleroderma also would love to have some kind of outcome measure. So we really need long-term evaluation of patients. We need to have sensitive assessment tools so we can better detect differences that we think are clinically meaningful. And this long-term evaluation is costly. Typical drug trials are not going to go on for 10 years, you know? They're going to go on for maybe 6 months, a year, okay? So we really need these registries that we talked about, which are typically not the sexiest thing for people to want to fund, but what you really want is for your child to be followed for 10 years, 20 years. Then we can better ask you, how are the patients going to be in the future? Because right now we don't have that data. So that's where, like, this CARE registry has been a huge advantage. So study design issues for pediatric scleroderma. It's really hard to conduct a randomized clinical trial, double-blind placebo-controlled trial, right? That's the gold standard, but how many people here would eagerly sign up for that knowing that your child might be in the placebo arm, okay? That's really a hard sell, and that's a hard sell for the doctors. So there was one study that was done in localized scleroderma. It was done in Italy, okay? People in the US probably would not have done this because the doctors would not have felt that that was really potentially ethical since there are effective treatments available, okay? So there's damage accrues very quickly. So if the child has something like arthropathy or lung disease and you just give them placebo for a certain amount of time, that can be a difficult question as to whether you want to do that. So more typically, in CARE, we're thinking of comparative effectiveness, meaning that those 2 arms of patients are both on treatment, okay? So we're having standard treatment, but we might be comparing it to another treatment. So we're going to compare the response of different treatments to each other, and we need very sensitive assessment tools for this because we're not comparing it to placebo, where you might expect a bigger difference. We're trying to compare to two things that we think are effective, but we want to try to tell what's better. And so this difference, instead of being 50%, maybe it's 20%, but that is still meaningful because we're trying to work towards optimizing therapy. So do we actually need treatment style studies in pediatric scleroderma? For systemic sclerosis, we're using the adult data, okay? But there are differences between adult and pediatric disease for both systemic sclerosis and localized. So we have different disease patterns and problems. Localized scleroderma is much worse in kids than it is in adults. Systemic sclerosis, Dr. Stevens told you, is better, but there are issues for both because there's a longer disease duration for both systemic and localized if it starts in childhood. And the disease can affect their normal growth and development, and so they have a risk for major functional impairment. So I think we all argue that, yes, we need pediatric trials. As Dr. Moore also told you, that kids metabolize drugs differently. So collaborative work is essential for this. We need to ensure that we have sites, not just one site, because we want to make sure we get representative patient samples, because we want to know that, you know, if we treat the patient in New York, it's going to be the same as if we treat the patient in Colorado. And we want to ensure that we have adequate numbers. So we formed this collaborative network to try to help us with this. So CARA was begun in 2002, and its mission is to conduct collaborative research to prevent, treat, and cure pediatric rheumatic diseases. So it's a bold, you know, desire. We're not there, but that's our goal. So our vision is that we have a world free of limitations from pediatric rheumatic diseases. So we put ourselves all out of business, which would be fine. And our values are that inclusiveness, trust, impact, and innovation. So the Childhood Arthritis and Rheumatology Research Alliance, and it's an investigator-led research network, includes over 90% of the pediatric rheumatologists in North America, so US and Canada. It's over 120 sites, over 550 members. We've had $60 million in research funding, which is sadly not enough. We have strategic partnerships with Arthritis Foundation since 2015, which has really led to us being able to do the registry. So the first CARA registry had 10,000 patients in it. Most of it was juvenile arthritis, 6,000, and it had about close to 400 localized, 64 systemic. That is the world's largest pediatric rheumatology research database, okay? So we started a new one to get better data, so we're trying to increase patient engagement, and we're trying to establish ties outside. So the concept of the CARA registry is it's a platform for laying on different studies, and this is only possible with a lot of funding from National Institutes of Health, NIAMS, Arthritis Foundation, as well as other institutions. And the idea is we're trying to have long-term follow-up of the patients. So when the patients sign the consent, they're signing consent that says it's okay if we contact you for 10 years, and ideally we might want to contact you for 20 years. So you're no longer a pediatric patient, but we're trying to get emails so we can follow up on what's going on with you. And we can put on observational studies, we could put on randomized trials. So comparative effectiveness, then I said. So we need a limited number of treatment regimens to study, and we need to agree on which regimens to study. So this was from a survey I had done to ask people, how do you treat? So I said before that, 95% of the CARA members, they agree on using methotrexate and steroids. But I gave them a case of a 4-year-old girl with a linear scleroderma lesion. And I said, specifically say, how would you treat? So we ended up with 12 different initial methotrexate regimens, and then the different color bars are how long they would treat, and then corticosteroids was even worse. So it ended up being that pretty much everyone was doing their own thing, okay? So it really took a lot of time and effort to try to whittle it down. So we got from the 12 initial regimens to just agreeing on one regimen. For the steroids, we agreed on 3 patterns: no steroids, oral steroids, or IV steroids, and that took about 2 years to do. Okay. But then that made it possible for us to do a pilot study where we could try to test those 3 arms and just observe how they did. This is underpowered to say which arm is better, but the idea is it's expensive to do these studies, so we did a pilot study where we looked at 50 patients with active disease, moderate to severe, so we could try to see what are the issues with doing these kind of studies. And we followed them for 1 year with many different measures. And so from these 50 patients, we had patients enrolled into each of these 3 arms and ended up with about 60 to 75% of patients staying on the arm. So we had dropouts in each of the arms. We had some changes in the regimen because of adverse effects in each of the arms. And then we also had treatment failures in about 20 to 25% of the patients. We looked at several different assessments. This is a bar chart just asking the physician to rate the patient compared to baseline for each of the treatment arms. This is methotrexate alone, this is methotrexate with IV steroids, methotrexate with oral steroids. So the majority of the patients, regardless of which arm they started in, were rated as having a major improvement in their activity status or a moderate improvement. So for each of the arms, and again, this is underpowered, so even though it looks a little better maybe for the steroid arms, we can't really conclude that, okay? So only one patient worsened out of these 50 patients, and that patient had a disease flare from month 9 to month 12, okay? I think it's very interesting to try to, and so then if we look at some of our assessment measures, so this is just an example that Dr. Torok put together of like how the patient looked initially and then after treatment. And if we look at our skin activity score, you know, baseline it was 7, 7, or 4, and it went down to 0.5, 1, or 0. So that measure seems to work pretty well. Physician scoring of activity also changed significantly. So starting out at 4, 6, or 4, it went down to 1 or 0. Damage did not change in our skin scoring or in the physician scoring, okay, which is not a big surprise. So it looks like we have tools that work. And then I think it's very interesting to consider that, you know, 20, 25% of patients that failed these treatments, okay, and failure means that the physician gave them more treatment than what was prescribed in the CT, in that consensus treatment plan, okay? So what we found was different between the ones who failed and the ones who did not was their subtype pattern. So like we might suspect, those that failed tended to have deeper subtype, more severe disease. They had a lesion located on the trunk, they had an extracutaneous involvement, and they were, there was a higher frequency of non-Caucasians, although the majority of patients were Caucasians. Approaching significance was maybe older age of onset of disease and lesions located on a limb. So with the SCORE study, you know, we're hoping to gather similar data because the patients that are eligible are the same that were eligible for the CT pilot. As Dr. Torok said, we're going to be looking at methotrexate as well as cell substandardized arms, and we can combine this data to see, do we find the same factors associated with treatment failure? And this is, again, going to help us decide, oh, this patient is likely to need more treatment because they have these risk factors, okay? And again, there's a high rate of relapse, so following them long-term beyond the 1 year is also good to tell us who's more likely to relapse. So these registries are really important for getting at a lot of information that families want. Okay, then we go to Anne. Yeah. Oh, sorry.
You go back and forth too much.
Yeah.
All right, hot potato. Hot potato time. All right, I'm just doing a couple slides, and then I think I kick it over to Anne. So these were just a few slides we just put in because we just came back from a Chicago meeting with the American College of Rheumatology, which is an adult mostly and also pediatric rheumatology conference. So in adults systemic sclerosis, they just released the results of the phase 2 trial in Orencia, or also known as Betasept. So this is an injectable medication once a week. They enrolled about 43 patients in the placebo and the treatment arm. And they basically used a certain skin score at 12 months as the outcome, but they also collected some quality of life and other measures, and then also safety profile as well. The other medication that was reported was a phase 3 trial, Actemra, also known as tocilizumab, again, an injectable treatment once a week. They enrolled about 43 patients in each, 104 in each arm. I duplicated my slide. Again, they use the skin score and then some lung function for their outcome. So just showing you the scale of the skin score, it did decrease. This is the placebo versus the Betasept. So it was helpful in decreasing the skin score, but not significantly. That's more of a statistical thing, but if you don't reach it with statistics, unfortunately, they kind of see it as a quote-unquote negative trial. I put tocilizumab side by side next to that because that had the same outcome. The patients on placebo had the change of the skin score. They had more change, whereas the ones with the tocilizumab, the skin score decreased because you don't want a high skin score. You want it to decrease over time. Same thing with the lung function test. So this was a secondary outcome. So a lot of these patients with adult systemic sclerosis have interstitial lung disease, so they use the pulmonary function test, specifically use the FVC, which is part of the pulmonary function test to see, sorry, I'm doing something annoying.
Yeah, that's really bad for the recording.
All right, is that better? I should have just clipped it. Can you hear me?
Yep.
Okay. Sorry, that was annoying for you guys. Okay, so just looking at the lung function test, this is a placebo arm, this is a betacept, so you don't want to see the lung function worsening. So you can see that the betacept or the drug arm actually had less, it basically was stable. The lung function maybe went down a little bit, but not a lot, whereas it kept going down in the placebo or the non-treatment arm. The same thing with the tocilizumab. You see the patients in the tocilizumab group, the function test just kind of stayed the same, so that's great. It stopped the disease progression in the lungs, whereas it kept going on with the placebo, so the function was worsening over time. So big picture is that even though they didn't meet the primary outcome statistically with the decrease in skin score, they met some of these secondary outcomes, which is decline in the pulmonary function. They stopped the decline in the pulmonary function test, both of these medications. And I didn't mention it, but they had quality of life measures, including this composite CRIS measure that has a patient quality measure in it. And they were the secondary outcomes, and they were actually significantly improved or changed in the patients on drug versus not on drug for both of these medications, abatacept and tocilizumab. So the next question is, okay, well, this looks pretty promising. Can we maybe do this in kids with pediatric scleroderma? Because when we look at these drug trials, what's helpful, even though these are adults, they do look at safety and infection rate, things like that, and they didn't see any red flags. So no major flags as far as infection over the placebo or any major adverse effects versus a placebo. But obviously kids are different, so we need to think of different clinical outcome measures. Now we kick it over to Anne. Do you want this or do you want the little?
I'll take this because I'm going to be very brief here. I'm charged with talking about genetics. It is lunchtime. So I would like to limit this to a shameless advertisement. Well, first I just want to show my enthusiasm for what Dr. Lee and Dr. Torok have told us. It's such a darn exciting time. 20 years ago when I became a rheumatologist, people were still saying systemic sclerosis has no treatment. That was you have this and I'm sorry. So now we have these amazing treatments, and the biomarker studies and the thermography studies, they make me think about patients that have to come several hours or take a flight to Seattle to have their clinic visits. Maybe we can do a blood test at their local lab. Maybe we can have them do thermography on their iPhones and send us the pictures and figure out if their disease is active and adjust their medicines over the phone. So I think that the future is super bright. Of course, what we would like is a cure. And so Dr. Torok and I have initiated a whole genome sequencing study for systemic sclerosis patients with our collaborators at the NIH. And we are recruiting for this study. We are inviting patients with systemic sclerosis and their parents so that we can compare the genes of the child to the parents. If siblings would like to participate, that's interesting too, because we can compare the genes between the affected child and the unaffected child. And we're hoping to find genes that cause this very early onset systemic sclerosis. Dr. Torok is here to enroll people. If you'd like to participate, you can sign up today. You can spit into a tube today and participate in this study. And we will send it to Bethesda, Maryland, to the NIH for whole genome sequencing. So see Dr. Torok if you're interested. There's another study at the NIH done by a different investigator, one of our collaborators, Dr. Ryder, and it's a twin SIB study that she's had going since 2003. And she invites people to contact her. There's information in your packets about this. This is a visit to Bethesda, a whole evaluation, and she's doing biomarker studies, urine studies, and she's comparing the scleroderma patients to myositis, to arthritis, to a whole bunch of different autoimmune diseases. So it's a different approach. You can participate in both. We do work with her. She's our collaborator, but you have these two options to participate. We have a physician panel at the end of the day today where we're going to take lots of questions, and we also invite questions, of course, informally over lunch, which everyone's eager to get to, I know. So enjoy.
All right. So this is a thank you. This is a thank you, guys.
Boom.
Boom, we did it in our picture.
Okay, thank you, you guys. Okay, it's a